Okay.
Okay. As you know, there are two kind of, first, a lymphoma means a malignancy of the lymphocyte. The lymphocyte is a white blood cell. It's one of many kinds of white blood cells. And the lymphocytes mainly, the white blood cells are attuned to fighting pathogens, infections, foreign invaders, immunity, if you will. So there are a number of kind of lymphocytes, but the main three are B cell, and that's about 85% of lymphomas. T cell, which is about 10 to 12% of lymphomas, maybe 13%, and then others like null cell and all sorts of things that comprise the rest. But of the T cells, they're divided into peripheral T cell lymphomas, and then others, including the cutaneous T cell lymphomas. So mycosis fungoides is unusual, but by no means rare. I have several dozen patients that I follow just in my practice. And of course, someone like Madeline Dovek has hundreds, if not thousands, of patients that she's treated through the years. The first thing that has to be done, I'm going to put to do. First thing is we're going to review the biopsy. When pathologists use words like suggestive of, consistent with, those are qualifying words because it means that there's something either not done yet or they're not exactly sure. It would seem logical. You look at something on the microscope, if you're knowledgeable, you know what it is. But I can't tell you how difficult the diagnosis under the microscope is. That's why pathologists are in training for 8-10 years before they're allowed to make these kind of diagnoses. Right. But you've had two pathologists. Dr. Cooper Hurd is a young but very well trained. He looked at that first one and it wasn't really consistent there. Dr. Wesche, W-E-S-C-H-E, very experienced. He's not as old as I am, but he's a very experienced pathologist. He looked at it, he said consistent with. So that means he's pretty sure. Now, what do they need to make absolute sure? Well, I'm going to get Dr. Wesche to look at the first one, look at the second one, and then I want him to do immunohistochemistry or PCR tests. And those are the actual DNA tests on that biopsy itself, looking at the precise cells, finding the cancer cells in that biopsy. This is acting like mycosis fungoides, but as you know, it can look like, so there are a lot of other things that can look like it. So before we go off on a tangent treating mycosis, we have to be 100% sure, or as sure as is possible. And we may, to review the biopsy, we may even go to a referral lab. There are people around the country that all they do all day is look at this. Kind of boring, I think, but still,
Somebody got to do
somebody has to do it. There are several centers around the country, including the lab at MD Anderson. They're excellent at looking at these iffy things. So first thing is that I want to be sure what we're dealing with. And because I'm getting ready to prescribe the next step after what we would do after Valchlor. I'll tell you about that in a minute. So the first thing is to get as precise a diagnosis as possible. Sometimes the best they can do is to say consistent with. All right, so let's assume that our reference labs, Dr. Wesche and everybody around the country, agrees that Kyle has mycosis. Well, the next thing is that and we're probably gonna do some of this about the same time, we're gonna stage. Stage means to, like an army, gets all its forces together, gets ready to do something. That's what we're doing. We're getting all our information together. And that would include some blood tests that you've not had, and maybe some imaging, like a CAT scan. I don't know that we'll do that necessarily, depends on what we find. And we'll look at blood imaging, and there's some specialized blood tests called flow cytometry. And we'll arrive at a stage. Right now, this looks like the earliest stage to me. Now, I know these lesions have been treated, so that kind of alters things. Staging doesn't change as you go through one's disease. That is, someone may present with a stage 1, but we don't really say, okay, it's stage 2, stage 3, stage 4, because it's all altered by treatment, of course. But it's important to assign an accurate stage. Oh, thank you. An accurate stage.
But these blood tests, and like if you do a scan and things, we're trying to determine, make sure that
where disease is.
Right, that it hadn't affected the organs.
That's correct. That's precisely the case.
Right
now it appears as he is a stage 1, and in the other staging system, it would be a T1. That's what it looks like.
Okay.
That means that you have patches, not plaques, but all patches, that are less than 10% of your body surface area. That's why I had Holly come in and measure this.
Right.
And it is far less than 10%. I'm going to feel on lymph nodes in a minute, but I doubt that there are any lymph nodes available. But that's what it appears to be at first.
And I'm not trying to get ahead of you, but this is the burning question that he has. I
Right.
mean, this is it's not a curable disease, but it's treatable. Is that accurate?
That is accurate at this point.
Okay.
That's correct.
Okay, it's saying that he has what we think he has.
See what he has.
Right.
Yeah, we're getting a little ahead of ourselves,
Okay,
but
I don't-
that's an important question. This is immensely treatable. I told you at the outset that frequently, even younger people like you, frequently it does not affect life expectancy, though it may, and it may require some treatment down the road. But it is a disease that is not curable at this point. And I keep saying that because few diseases are becoming more understood with more medicines to treat them than lymphomas these days. Right now, it is not curable, highly treatable, and the survival.
And also manage. Would a good word be manageable?
Well, I told you early on that the problems people have, at least in the early stage of this disease, are not threats to their lives. They're threats to your comfort and to your productivity and your quality of life. And that's what we have to manage.
Right. Okay.
So the first thing we'll do is review the biopsy. About the same time today, we're going to start a little bit of blood work so I can kind of get an idea there. And then the last is RX, or our therapy, treatment.
Yes.
There are basically 3 or 4 types of treatment. The one we're interested in now is called skin-directed. Unless we found some visceral involvement, or visceral means organ involvement or whatever, doubtful. But if we
Something
did,
you
that
have
would
to
change
check.
us to a systemic therapy. So skin-directed therapies are things like steroids, which you've had, responded to, mustard. Valchlor is a type of nitrogen mustard. Creams, salves, that type of thing.
Is there anything to this ultraviolet light?
Well, another one is the PUVA and PUVB. For the thinner lesions, we would use the PUVB. We could use that. Light box is tedious and time consuming, and generally This can more likely be handled with creams and salves on the lesions themselves. I think Holly counted 9 of them to be sure.
Right.
And so, and they may change, regress, or progress, or whatever. But right now, probably Lightbox is gonna be more trouble than it's worth for you. Although it's generally safe, it's like getting a suntan all over it, except you get a substantial suntan. And there's side effects to that, of course. You know, there's secondary skin cancers and so forth from heavy ultraviolet light. I mean, everything you read in the summer is don't get sunburned, and that's what they're doing. They're therapeutically giving you a sunburn. All right, so nitrogen mustard, skin-directed therapies. Then there's one called retinoids, which is what I'm going to prescribe here most likely to you. Retinoids are creams and salves, also oral. They can be used oral, but that would be under systemic therapy. The skin retinoids are like bexarotene, targretin, and these are gels and creams that you use. The problem I have with the treatment so far is that you've been so very sensitive to the mustard. You know, Dr. Clemens only used it once and then 2 days off. Is that right?
That's correct.
Yeah.
3 days.
Oh, 3 days.
It's it's every 3 days.
Every 3, yeah. So you did it one day, then you were off 2 days and used a steroid between. Well, that's a good way to do it, and he described that she had a lot of skin irritation to that. It looked effective, but nevertheless it was, so that's an option too. We can try the retinoids. The retinoids are more expensive because of the drugs in them, but people typically tolerate the skin typically they tolerate it better. That's probably what I'm going to do once we see the staging and make a firm diagnosis, which shouldn't take very long.
So
There are other things. Let me finish.
Okay, I'm sorry.
Systemic things. Systemic things are chemotherapy, which we try to avoid in this case if we can. Systemic therapies are like extracorporeal photophoresis, is where they put you on a machine. We cannot do that here. The closest place would be Baylor or Houston. And that's where they put you on a machine a couple days a month, and it circulates your blood through the machine, and the special ultraviolet light kills these cells, and it gradually remits on the skin. Generally speaking, that's for more advanced cases than yours, but there are other things. And we also use retinoids for systemic therapy. So this is what I think we ought to do today. I'm going to get some blood work beginning on you. There'll be a little bit more once we confirm the diagnosis. Today I will get Dr. Wesche to call over to get your other biopsy, look at it, and then we'll discuss sending it off for a referee opinion. And we'll just see how that goes. So we're going to try to stage you based on the blood work today. We'll decide whether it's worthwhile to try to do a CAT scan. CAT scan is pretty low risk, but if you don't need it, we don't want to do it. And then we'll decide on therapy. I'm leaning toward retinoids. Targretin is what I'm leaning toward right now. It's a cream.
After you get a positive diagnosis and you start whatever your therapy and whatever you're doing, where does MD Anderson come in?
MD Anderson is a marvelous referral source. This is a fastball down the middle for us locally.
Okay.
I think that if we have trouble, I think if this progresses or if I find it more advanced, although I know what Dr. Dubik's going to say, she and I are about the same age and we've worked together for many years. I kind of have a feeling, but they have so many avenues of clinical trials and research. I mean, if we have trouble, you're so young that I'll want to get her opinion as far as new drugs, investigative new drugs. You know, I'm not patting myself on the back, but I'm very familiar with the standard treatments of this disease. What I would be looking for from Dr. Madeline Dudick, D-U-V-I-C, M.D., Ph.D., both, is the where or if you fit into a clinical trial or investigating new drugs.
New things are coming out all the time.
Well, more so in lymphoma than many other cancers.
Wow.
And if sometimes I get in a bind that I just need someone to look at it, she's the go-to person.
Okay.
I think that as far as a second or third opinion, you will not find any better.
Okay.
And she's a nice lady too.
Good.
So at any rate, that's my plan. I think it's doable. I think we ought to take a breath and get some of these things done, see where we stand.
Okay.
I'm looking probably to start you on some targretin gel.
Okay.
Which you can put on there, and it's a pretty good response rate. Now,